Assalamu alaikum. I will just talk and highlight about the best talk about the RA in the previous ACR. So I will start with this study, which talking about the clinical and radiographic results of tapering and withdrawing conventional DMARDs versus stable treatment in patients with RA in remission, 3-year results from a randomized controlled trial. So the background of this study, the tapering of DMARDs to achieve drug-free remission is potential treatment goal, and the long-term effect of tapering and withdrawal among RA patients in remission remain unclear. So this study is considered as a follow-up of the 2 previous studies on the same population. And the conclusion of the first one, it was in first-year data from Architect Rewind trial showed the half dose of conventional DMARDs was not non-inferior compared to the stable conventional DMARDs. And the second study showed that 2-year analysis indicated that drug-free remission could be achievable for subgroup of patients. So the main objective in our study here to compare a 3-year of clinical and radiographics outcomes of 3 conventional DMARD treatment strategies among RA patients who sustain on remission. So the study design was multi-center, open label, RCT. The inclusion criteria are a patient who in sustained remission for more than 1 year on a stable conventional DMARDs without using biological or synthetic DMARDs, and also they should be in dose remission with no swollen joint. So the intervention of our study, the number of patients was 160, and they are divided into the 3 groups. The first group, those patients who are on stable conventional DMARDs, and the second group, they started with them with a half dose, and the third group, they start with a half dose in the first year, then after that, they withdraw till the end of the journey of the study. So regarding the primary endpoint, they looked to any disease flare during the journey of the study from the 0 to 36 months, which defined by DAS score more than 1.6, or if there is any change in DAS score with the more than 2 accounts of the swollen joint, or if there is agreement between the physician and the patient that there is significant flare-up. And regarding the secondary endpoint, they look to the remission through the DAS and ACR EULAR Boolean 2011. Also, they're looking for the radiographic joint damage by using the Van der Heide modified Sharp score, which is scored by 2 radiologists blinded to treatment and clinical information. Just a small talk about this is the Van der Heide modified Sharp score. It's a score used to measure any damage in the joint, like erosions or joint space narrowing. So more account, that means more joint damage. Also, they look to the DMARD and the steroid used during the study, and also the safety. So the results. Regarding the clinical features of the patient were distributed equally for all the 3 groups. Even we can see here that the majority of them, they have been in remission before to enter the study. And by the way, the conventional medication was methotrexate. And the majority of them, they have been on MTX as a monotherapy. So regarding the flare-free survival at the end of the study, at the 36 month, we can see 80% from the first group who have been on a stable dose, they have a flare-free, followed by 57% in the second group who started with the only half dose. And eventually we can see the last group who they start at the beginning with a half dose in the first year. Then after that, they withdraw. We found only 38% they achieved flare-free. That's mean more than 60% they have flare-up. Regarding the non-inferiority margin of 20% risk difference of the flare was not met, and we can see here obvious the half-dose patients or group versus a stable dose. We can see the confidence interval across the non-inferior margin. Also, the last group, the half-dose to withdraw, they are away from non-inferior margin. Regarding the disease activity, we can see here clear in the middle, those patients, the third group, they have a high flare-up. And eventually, after the first visit, all of them, they achieve the remission. Also, if you have to look to the mean of the DAS score, it's almost they have the same percentage. And regarding the ACR EULAR Boolean 2011, we can see 18% the absolute risk difference between the first group who has been on the stable dose versus withdrawal. So 60% versus 78% in the stable group. So here we are, we can see the radiographic change after 3 years versus the baseline. We can see here at the end of the study, the light blue color with the triangle, which reflect the third group, those group who start with a half dose in the first year, then after that they withdraw. So we can see the score is high score. That means they have more joint damage. Also, we can see here clearly that the third group, they received and increased the dose of the MTX, and also they gave them the biological DMARDs. Also steroid, we can see it, oral steroid was used more than one time on the third group, also in the more than one time in the intra-articular injection in the second and the third group. Safety, honestly, it is almost the same. There is no significant difference between all the three groups. So the conclusion of the study, tapering were associated with increased risk of a flare, but the majority regained remission after the flare. Sustainable drug-free remission was achievable for a subgroup of patients, around 38%, but others ended by intensified DMARD treatment after tapering. Attempt radiographic joint damage was statistically higher after tapering to half dose compared to the stable conventional DMARDs. This trial provides a long-term data that can confirm and shared decision-making. So the second study will talk about the telitacicept, which is considered as a human recombinant fusion protein targeting and neutralizing B lymphocyte stimulator and the proliferation-inducing agent in RA patient with inadequate response to the MTX. So as a background, we know that the telitacicept, it has been approved in China in 2021 to treat moderate to severe SLE. And by targeting beta cell, by blocking this is the BLyS and the APRIL pathways. But the objective of this study, they're looking for the efficacy and the safety of the telitacicept in RA patients who have had inadequate response to the MTX. So regarding the study design, it was a randomized, double-blind study, and the inclusion criteria, any RA patient who were inadequate response to the MTX. For example, they have more than 6 tender on swollen joints, they use steroid, they use more than one painkiller medication, and they exclude any patient who have been on biological treatment. So the study was divided into 2 parts. Part A, which is double-blind, they divided into 2 groups. The first group, they received the telitacicept, 160 milligram subcut once weekly, and the other group, placebo. And the primary endpoint was at week 24, and they looked to the ACR20 response. The second part, it's a follow-up. They shift all the patients into the telitacicept till the end of the journey of the study at week 48, which is secondary endpoint. Here they look for the other disease measurement like a HAQ, pain assessment, patient and the global disease assessment, and also acute phase reactions. So what about the results? All the clinical features were distributed equally for the patient. The number of the patient in the placebo was 119, and in the telitacicept group 360, and we can see the majority of them also they have been used the steroid and painkillers. The good thing that the majority of them they are seropositive, and also we can see on a high of the acute phase reactions. What about the The primary endpoint, significant more patient in the telitacicept group achieved an ACR 20 versus a placebo, 60% versus 27% with the significant p-value. Even the ACR 50 response, it was achieved on the telitacicept group. Regarding the DAS28 ESR less than 3.2, we can see here clearly at the week 24, it was significant achieved in the telitacicept group, 14.7% versus 5% on the placebo group with a significant difference. And also we can see here clearly a reduction from the baseline into the DAS28 ESR from the beginning till the end of the journey of the study with a significant difference versus the placebo group. Regarding the other measurement tools in the secondary endpoint, all of them are part of the HAQ, pain assessment, patient global assessment, physician global assessment, ESR. It is significant, achievable in the telitacicept group versus the placebo with significant p-value. Regarding the radiographic changes, there is a significant more patient on telitacicept group. They have at least joint damage, a part of the erosions and joint space narrowing. So regarding the safety and the adverse events, both of them, they have the similarity. There is no any much difference between both of them. A part of the serious adverse event, a part of the, even for the infection, both of them, they have more chest infection. But there is no death. So what's the limitation of the study? There was no active comparator, and also the study was conducted in Chinese patients with limited racial diversity. So the conclusion of the study, the primary endpoint for this phase 3 was met with significant more patient in the telitacicept group achieving an ACR 20 response at week 24. Compared to the placebo group, the telitacicept group also showed a significant higher proportion of patients achieving an ACR 50 response, low disease activity measurement, and least progression of the joint damage. So the telitacicept demonstrated the clinical efficacy was favorable safety profile in RA patient who had inadequate response to the MTX. This is the last study. I will talk about it. It's talking about the infusion of the etanercept into the peripheral lymphatic, which is significantly reduced disease activity in RA patient with inadequate response to the subcutaneous Enbrel. So regarding the background of this study, lymph node considered as the first peripheral site of antigen presentation to the immune cells in RA. During active RA, increase of inflammatory cells from the joint to the lymph node. So they found there's a defective efferent range from the lymph node, result in lymph node engorgement, and that can cause increased swelling and joint inflammation on ipsilateral site. So the main objective of this study to evaluate the efficacy and safety of the etanercept by peripheral lymphatic infusion in RA patient who had inadequate response to the subcutaneous etanercept. Study design, it's only 10 patient phase 1b RCT in RA patient who inadequate response to 50 milligram subcut etanercept for 3 months. Then after that, they switched to the 25 milligram etanercept by peripheral lymphatic infusion through the device, they call it nanotopography microneedles, NTM, in the dorsal forearm. So they start with the 25 milligram infused over 1 hour weekly in the first 12 weeks. Then after that, every 2 weeks for second 12 weeks. Then after that, monthly for the third 12 weeks. Alternated between the forearm every other dose. So even they look to they measured the lymphatic pump rates by using lymphatic imaging through near fluorescence with indocyanine green dye 2 before and after etanercept lymphatic infusion. So what about the results? They found that DAS28 CRP was dropped from 5.4 to 3.5 at the end of the study. Also, they found the patient global assessment of the disease activity and pain decreased by 60% and 77% respectively. Both remained stable, decreased dosing frequency. Also, they found that lymphatic pumping rate increased from 1 to 2.9 pumps per minute. That means there is no side effects. And also they noticed at the beginning that the TNF-alpha level initially was increased, more than 30%, but at the end of the study, it reduced down less than 20%. Regarding the safety, they couldn't report any serious adverse event, just only mild erythema at infusion site. So the conclusion of the study, local lymphatic injection to lymph nodes ipsilateral to inflamed joint was associated with improvement in DAS28 overall, not just ipsilateral joints. Need to define mechanisms by which local lymphatic injection has systemic efficacy when subcutaneous injection were not efficacious. Large placebo-controlled clinical trial is needed to confirm the results. With this slide, I would like to end my talk. Thank you so much.